This is the first program in the Radiography Limited Operators course, and we're going to do a series of introductions during this program. Some of this will overlap the Getting Started video that you've already seen. In this class, we're going to introduce the course, radiography, important terminology, the process of producing a radiograph, the equipment, and a little bit about patient interactions and management. This course is designed to prepare individuals with healthcare backgrounds to perform a limited number of radiographic procedures with full attention to the safe use of ionizing radiation. Those with healthcare backgrounds could include medical assistants, practical nurse, medical technologists, the RN, even physician assistants, or nurse practitioners. In most cases, the physician assistant is exempt from having to have a license to do radiography, but they often view the course in order to become more proficient at producing images as well as interpreting them. So we welcome that group. The specific objectives include providing content that is specified as core by the American Registry of Radiologic Technologists, the ARRT, in their limited scope of practice exam. Most of the states provide that exam for those seeking a license in the state. We will also illustrate some practical applications of selected principles, demonstrate selected procedures including the chest, thorax, extremities, and spine, and the skull content is available to you for self-study if that's either required by your state or you are going to work in a situation where you would do skull imaging. We want to encourage you to observe and practice selected procedures in a facility where x-rays are being provided as a service. We want to provide means for you to be evaluated by your supervisor on selected procedures in that facility. We also will provide means for the students to evaluate selected images and to specify changes needed to improve the image. This is often the flaw that folks have observed about limited operators. They may be able to identify the image is not acceptable, but they don't know what's wrong or how to improve it. And then also provide you resources to prepare to take the limited scope exam. The ARRT limited scope exam includes a patient care section, but we make that a prerequisite to this course. We don't teach the patient care portion. It's in the textbook that you have been provided, but we don't. We allow you some review and we provide some review questions on it, but we assume that you already have had most of the content necessary in patient care and management. We also will give you some laboratory or virtual laboratory opportunities and assign some clinical lab exercises. These will be helpful even in the digital environment, especially in the digital environment, for you to practice using that equipment and seeing what happens without actually x-raying a patient. In the clinical setting, we've provided forms for your supervisor and you to keep track of the images that you actually do and the procedures that you complete. That checklist, along with the practical experience guideline that will be itemized here as we keep going, need to be signed and returned. And there is a sample evaluation tool that you can copy and have your supervisor use to evaluate you on selected procedures. And then passing the test, of course, is the goal we all have, but it's greatly influenced by how much effort you put into the course. And we're always available to answer questions. To complete the course satisfactorily, you need to complete all of the assignments. This includes written assignments and tests, which you will grade yourself and then submit to us those completed and graded self-tests, just the answer sheet, not the entire test. These will be used by you as an indicator of your readiness to start getting ready to prepare for the limited scope exam. And there is a test prep system provided to you. Along with these completed self-tests, there is that procedures checklist that I mentioned, and we will need a final signature by your supervisor. Now, to introduce radiography, we have to go all the way back to 1895, when Wilhelm Conrad Röntgen discovered X-rays in Germany. He was experimenting with a cathode ray tube, which caused some kind of mysterious ray to pass through the tube, which was covered by a black cloth, and he asked his wife to come in. There was a phosphorescent material on a plate nearby, and when she placed her hand between the tube and that plate, he could see the bones of her hand. The rest, as they say, is history. As early as 1896, there were risks identified in association with this mysterious X-ray. Other important dates include 1920, when the American Society of Radiologic Technologists was formed, and they then formed the American Registry of Radiologic Technologists in 1922. This is the organization that produces the tests that you're going to take to get your limited scope license. They don't actually administer the limited scope exam, but they contract with states to sell the tests to the state, and the state administers the exam. Then state and local organizations formed, like the Nebraska Society of Radiologic Technologists, and most states formed organizations that affiliated with the national or the American Society of Radiologic Technologists. 1981, there was a federal law passed that encouraged states to voluntarily comply with minimum standards for those who operate X-ray machines. And in 1996, Nebraska was one of the states that agreed to do that, and they implemented rules and regulations in accordance with that law. It's included having anyone that operates an X-ray machine have to pass a minimum competency certifying exam. And the goal, of course, is to establish those standards, the minimum safety standards for those operating X-ray machines. Now, your state standards may not be the same as Nebraska's, so be sure you do the research to find out exactly what your state requires, and that this course meets those standards, and the tests we're preparing for you for will meet those standards. In Nebraska, all operators of equipment which produce ionizing radiation for the purpose of exposing human clients must be licensed. That's the term that's used in Nebraska. There are terms used in other states to designate somebody who has met whatever that state's minimum requirements are. And then in Nebraska, again, you must pass the ART test, and you have to receive a 70% on the core and 65% on all the procedures, and you get 3 attempts. If you don't pass any of the sections in 3 attempts, then you have to get additional education before you try the test again. Other states have similar requirements, but their passing score may be different, as an example. And then again, in Nebraska, all operators need an average of 12 hours a year of continuing education, or 24 hours in a 2-year biennium renewal period. The exceptions in Nebraska are podiatric and dental operators, and there is included in your manual certain specific references to continuing education requirements for Nebraska. Again, this is going to vary from state to state, so be sure you check what your requirements are in your state. If you are required to get continuing education, and if that education does not have to be approved by an agency like ASRT, then we have a website that will help you meet your continuing education requirements. Okay, it's time to get down to work and introduce some terminology. In your workbook, you have this list of terms, and we're going to see the terms as we go through the next slides. One way to introduce these terms is to go through the circle of production. We're going to begin this circle at the top at 12 o'clock, if you will. We need to determine what type of detector. Is it an analog system, that is film screen, that requires processing, a processor? Or is it a digital system that uses a cassette, which would be cassette-based, or CR, computed radiography? Or is it a direct digital system? With this system, you produce the image, it immediately appears on the monitor. With a computed radiography, you have to take the cassette to a processor, and the image is converted from what was on the cassette to a visible image on a monitor. With film screen, of course, you have to take the cassette to a darkroom, unload the film, and run it through a processor. So which type of detector are you using? Now we're going to move to the control panel. Here you will manually select probable exposure factors. That is usually determined by either a technique chart. Sometimes your equipment has default techniques that come up when you tell it that you want to do a wrist, for example. But somehow you have to say, I think I'm going to use this kV, this MA, this time, or this MAS. Or you may be selecting automated or automatic exposure. We'll talk more about kV, MA, and time as we go through this our sessions together. kVp determines the energy of the X-ray as it comes out of the X-ray tube. The MA determines how many X-ray photons will be coming out of the tube, and the time, of course, how long you allow that those X-rays to be created and pass through the portal to the patient. Then you're going to place an RL on the cassette or on the table. You have to identify the right or left side of the patient or the right or left extremity. You put it in the appropriate location. You correctly position the body or the part in alignment with the X-ray beam's central ray and the center of the detector. Determine the patient or part thickness, and then when you return to the control panel to make the exposure, you may refine those probable exposures that you've already preset after you determine how thick the part or the patient is. Restrict or modify the beam by use of filtration, collimation, or grids. Then refine the exposure as I've mentioned. Begin the exposure by pressing the first stage of the exposure, which brings up the rotor to speed. It's a two-step operation. And electrons will be emitted from the cathode, strike the anode, and at that point there's a conversion, energy conversion that occurs when those high-speed electrons are converted into a little bit of X-rays and a whole lot of heat. The X-rays that emerge from the X-ray tube through the collimator to hit the patient are called photons. They are either absorbed, scattered, or penetrate all the way through the part. Photons that have penetrated, as well as the ones that are absorbed, create the invisible or latent image in the exit beam. That invisible image strikes the detector. It receives that beam, that energy, and transforms it in some way to a visible image. Analog images require a processor. Computed radiography requires a plate reader, and the direct digital immediately shows you an image on the monitor. The image is then viewed and evaluated to determine if it's usable, and if it is, it's forwarded on to the physician for interpretation. Now let's look at these terms one by one. A radiograph is a record of X-rays that either penetrate a body part, are scattered, or absorbed, as I mentioned in the previous slide. The blacks within the image represent the absence of absorption or complete penetration, if you will, to the image receptor. The whites within the image represent nearly complete absorption of the X-rays by the tissue. The grays within the image represent tissue that partially absorbed the X-rays or interacted with the X-rays to produce scattered rays, some of which reach the receptor. As you can see in the image on this slide, air is being used to represent the part of the tissue that allows the radiation to pass all the way through to the receptor without being changed. Water is at the bottom of the image. It absorbs a lot of the X-rays and scatters quite a bit. Oil scatters more rays, but allows a lot of rays to penetrate. And right in the middle you see a piece of bone that's mostly white. So most of the radiation was absorbed by bone and gives us a white image. The latent image, the invisible image formed in the receptor after the X-rays have penetrated, been absorbed or scattered, but before they've reached the receptor. The receptor records the latent image. You can see these in the diagram, and you can look at that more closely in your manual. Here we see three different kinds of detectors. Either film is placed in a cassette with intensifying screens, and the latent image is stored on that film until it's processed. Or we have a computed radiography, cassette-based digital imaging, and the plate stores the latent image until the laser beam in a reader releases that stored energy and transforms it electronically to a visible image on the monitor. The third kind of detector does not use a cassette at all. The latent image strikes the detector and it is immediately transformed into an electrical signal in a 1 or 2 step process. There's no storing of the latent image to wait for it to be transformed. It's transformed immediately, either by 1 step or 2, but either way, it's immediately seen on your monitor as an image because its energy transformation has occurred right in the detector. The X-ray tube is the device from which the X-rays emerge, and on the left you can see the person holding a glass envelope with the tube inside of that glass. The middle image shows you what you would see if you took the collimator off and looked up inside the X-ray tube as though you were the patient lying on the table, and you could see the square from which the X-rays are going to emerge. The X-ray tube inside the glass envelope is embedded in or surrounded by metal, as the arrow points to on the image on the right, and that's above the collimator, which you can see at the bottom of that right image, and the arrow points to where you would find the X-ray tube when you go in to look at your X-ray equipment. That's where the focal spot is. That's where the X-ray tube lives. The control panel is where you select your exposure factors. The KVP, remember, controls the energy of the photons as they leave the tube. The MA controls the number of photons, and the time is in seconds or milliseconds, and those two can be combined to make a total quantitative measure called MAS, and you can also select automatic exposure at that place. Now you're getting ready to do the procedure, so a good first thing is to go ahead and put your R or L in the correct position, either on the receptor or on the table. Positioning is placing the patient or the anatomical part in the right position to get the optimum demonstration of the anatomy of interest. The central ray is an imaginary ray that comes out of the middle of the X-ray tube and strikes the middle of the desired anatomy. As you can see on the photograph at the bottom, the imaginary ray coming out of the X-ray tube through the collimator all the way to the receptor, but in between the X-ray tube and the receptor is the desired part, and it's been positioned to get it in the middle of the receptor and also having the central ray strike the middle of the part. Part ray, we used to say film, part ray detector alignment. Filters are anything placed between the source of the X-rays and the film, but usually refers to a thickness of aluminum placed above the collimator for patient protection. You can see the filter placed in this picture, not at the level of the yellow arrow, which is pointing at the focal spot, but it's the line below that, and you can see the word filter placed there. It's primarily for patient protection. The collimator is a device used to restrict the size of the beam to the area of interest. The size of the beam should never be larger than the size of the receptor. So you do that right there, as you can see the operator on the left turning dials to control the size, 8 by 10 or 10 by 12, however your receptor is identified by size, you control the size of the beam to match the size of the receptor or smaller. Now you're about ready to make the exposure. You do this by first of all pushing the first stage, and you'll have to figure this out on your machine, that causes the disc that you see on the left in the top picture to rotate, and you can hear that. It makes kind of a whirring sound. When it gets up to speed, you'll get an indicator, and then you push the second stage of the exposure. That starts the electrons from the cathode to the anode. It propels the ones that have been made available by your choice of MA and propels them across that little tiny space in the X-ray tube. When those electrons strike the anode on the left, you produce a few X-rays and a lot of heat. The X-ray beam then is made up of all the X-rays that have just been produced as those high-speed electrons have struck the anode. This is called primary radiation. And a byproduct of all this is a lot of heat. A grid is a device placed between a thick body part and the receptor to absorb scatter that we were talking about earlier and improve the quality of the image. You can see it here on the picture on the left with the big yellow arrow pointing to it. The number 1 represents X-rays that penetrate the body part and reach the receptor unchanged. They go all the way through the grid unchanged as well. The number 2 represents X-rays that are absorbed within the body and therefore produce that portion of the image that is white. Number 3 represents those X-rays that are scattered as they interact with portions of the anatomy, molecules, atoms, and they change their direction, they lose energy, and they would cause the image to be more gray. Therefore, we put the grid in place to absorb as many of those as we can. The image on the right shows the grid displaced from its usual position, and when it's reinserted, it will lay in that position that you see on the left, above the image receptor. Gonadal shields are pieces of lead in various forms and positions that are placed there to protect the patient's gonads. On the far right, you see some of various sizes that could be used for children, and they have a belt, and you can place them in position if you're doing chest x-rays or anything. And the thing that's important to note, you can shield the patient's gonads whenever it's possible to do so. Sometimes it's more beneficial than others, but you cannot interfere with the exam. So if putting the gonadal shield there will obscure portions of the anatomy that needs to be seen, then it's not recommended. Source to image distance is that distance from the focal spot where the top arrow is all the way down to the image receptor. It's not the end of the collimator, but it's where the X-rays are being generated at the anode, at the focal spot. Calipers are a device by which the operator can measure the body part's thickness, and from that go then to a technique chart to determine what the appropriate technique is supposed to be for that thickness. With the advent of digital imaging, we don't find calipers obviously displayed in many facilities because there's a lot more latitude in our selection of exposure factors. It's too bad because even with digital imaging, it's good to train your eye to what small, medium, large, extra large are with an objective standard of thickness. And at that point then you can still accept that the privilege or the benefit of digital imaging of being a little less precise in your exposure factor selection, but at least you've got the quantity of small within parameters that have been determined by measurement. The technique chart will either, as I've said before, be posted, a guideline for selection of those factors, or sometimes it's a default in your machine. But be wary, because a lot of times the default techniques that have come with the machine may or may not be good, and they really should be tested against our knowledge of what good technique is. Then they can be reprogrammed to be the techniques that we think are appropriate for a piece of equipment in that environment. If you need assistance or you'd like to have a technique chart for your wall, please go to controlthedose.com. The operator protected area is that place that you're going to stand while you are producing x-rays with the exposure button. The x-rays will be coming out of the machine, and only during the time that the timer allows, by virtue of what you've set or the automatic timer, only during that time are x-rays being generated. You don't have to worry about being too quick to get around the shield out into the room. They're not bouncing around. But during the time of the exposure, don't be like this operator. You can't really do that much anymore because of the location of the exposure button. But you're not to look around that protected area, but stay behind it while you're making the exposure. Unless, of course, you need to be out there to help the patient, then you wear a lead apron. And you should have a personnel monitor, as is depicted on the photo on the right, worn at the collar if you're wearing a lead apron, to measure occupational exposure. and we'll learn a lot more about that as we go. But that film badge, it used to be called, personnel monitor now, in some method is catching the radiation that you are exposed to, and you will get a report on a regular basis as to what that is. The last thing to notice on this slide is the way the apron not being used is stored. That's a good way to store lead aprons. They should be like that and not in a crumpled heap somewhere. We've mentioned before that film requires a darkroom with a processor which moves the films through develop, fix, wash, and dry. Computerized radiography requires a CR reader which scans the plate with a laser and converts the image to an electrical signal. And digital radiography does not require a processor but converts the X-ray energy into an electrical signal through 1 or 2 steps, as we've mentioned. But in each case, there's absorption, transformation, and an image made visible. You start with X-ray energy that is absorbed, transformed, not created or destroyed, but just changes its form, and then results in an analog visible image on the monitor. Now we're ready to evaluate our image. We're going to recommend this easy method. Your textbook has a bit more complex method, but you want to start out with A. Is all the anatomy on? Well, we can see on this chest image, at least I hope you can see, to the right of the image, which is the left of the patient, that a portion of the anatomy has been cut off. You can't see it. Is the body part correctly positioned? We'll learn about what constitutes correct positioning for each body part for each procedure as we go through the procedures, and you need to assess that. Is it properly rotated or not rotated? Is it correctly PA or AP? Is it lateral? Is it correctly positioned? And contrast is something that we are very concerned about in film-based imaging, and we control it with KVP and sometimes have to repeat the image if the contrast is inappropriate. In digital imaging, the contrast is no longer controlled by KVP. It's controlled by the algorithms of the software that the vendor has put in their equipment. But we're going to look at images with an eye for contrast anyway. Density was the film-based term for is the film overall black enough but not too black. The corresponding indicator for digital is called an exposure indicator. There are other terms, and you need to find out what those are for the equipment that you're using. It's usually a mathematical scale that tells you if the amount of exposure you used for that receptor was within a predetermined range that the vendor establishes and tells the operator, as long as you're within this range, then you've given the receptor enough radiation but not too much. And this is very important because we don't want to overexpose the patient, nor do we want to underexpose and get an image that's unacceptable because not enough radiation was used. We could do that with density on film. It was either way too black and was overexposed and we have to repeat it, way underexposed and we have to repeat it and give more radiation, but you don't have a visual clue like that with digital imaging. And then we care about everything else: distortion, resolution, detail, no motion, no artifacts. In this case, we do have an artifact. There's a little square towards the left of the image. That would be an artifact. Now, I know what it's there for, but we'd have to consider that that's an artifact. It's not part of the anatomy. We'd have to figure out what that is. And also, the image needs to be correctly labeled with the patient identification, the right date, right or left, whatever it is that you determined in your facility's protocols. A workstation is available to the operator. It's where the image is evaluated. You can do some manipulation of the image at that workstation, but it's not advised, because sometimes when you change the parameters of brightness or contrast and then refer it on to the physician, it gives him less information to do the manipulations he or she may want to do after they get the image. So it's not advisable to send it or to manipulate the image with the software before it's sent on to be read. PACS refers to Pictures Archiving Communication System. The whole communication system that produces the image, stores it, archives it, files it. All of that is included in the acronym PACS. Now we're going to practice. We're going to look for the X-ray tube. See where it is above the collimator? And then the table, which is under the patient. The central ray, we're going to find that on the right picture, the picture on the right as it comes out of the X-ray tube, invisible central ray. And the Bucky tray, the central ray goes through the part, and the Bucky tray is underneath the table. That's where a cassette in a cassette-based system would be inserted. So the central ray is invisible, comes out of the X-ray tube, goes through the part, and then strikes the image receptor, which is in the tray underneath the grid, and we call that tray the Bucky. Now we're going to look for, in this image on the left, the image receptor. Positioning of the part involves trying to determine how to get the patient positioned with reference to the image receptor as well as with reference to the central ray. The grid and the Bucky, or the grid, is where the red arrow on the right points, behind this vertical holder, but before the image receptor, if there is one. Not all the vertical holders have a grid. And if the grid moves, then it's called a Bucky. The Bucky is the mechanism that causes the grid to move. One more time, look for the grid Bucky and for the radiograph. The final product is the radiograph or image. Now in these slides you're going to look for the CR reader. The cassette-based system inserts the cassette into the reader, and the laser light scans the latent image and converts it to an electrical signal and produces it on the workstation monitor. Now that workstation monitor could have been from a CR system and it's now displayed there, or it could be direct digital as well. And then there's a physician viewing area, which is all monitors, and usually, always I should say, higher resolution than the monitors at the workstation. So anything that's artifacts or degree of quantum model, whatever is wrong on that image will be better seen on the physician's viewing monitor. In this image, all that we're seeing is measuring the part through the path of the central ray to determine either patient thickness or part thickness. Now here we go, another try. Where is the X-ray tube? Where's the collimator? Where's the control panel or console? Where's the operator protected area? And this brings us to, be sure you read the radiation protection rules on page 24 in your manual. The last portion of this presentation involves patient interaction and management, foundation of good ethics, character, interpersonal relationships, codes of ethics. All of these are found in the chapters towards the end of the textbook. The need for honesty, integrity, compassion, empathy. These are the things that make good healthcare workers. And as always, treat others as you would want to be treated. There are some specifics about patients' rights in the textbook and also about the parameters of informed consent. Legal considerations are actually based on morality and values. And from those we have determined some laws, and within those laws that apply to the medical world, we care about things like negligence or malpractice, assault or battery, false imprisonment, privacy, confidentiality, and the difference between libel and slander. Be sure to read those chapters at the end that include the things about legal considerations. There are some specific issues about patient privacy. By this time we all have heard about HIPAA. So understand those terms according to the text. Electronic medical records or electronic health records are the new standard. Comparing orders to clinical indications is what you're concerned about as an X-ray equipment operator. And the radiograph itself is a legal record, as we'll see here. And it must be properly identified with the right date, the patient identification. Be sure that the exam that's requested is what's being done. Any clinical data, any information that the patient brings that you can add to the record before it's being interpreted. Label that image with the correct RL as well as the ID, where the image is stored, who can access it, who can release those images and how they are released, and indications of radiation safety that are part of your facility's protocols. The electronic data as it pertains to the image includes the exposure indicator. Not all digital imaging records that indicator on the image, or does it follow the image through the system, but in some cases it does, and in some cases people require that the image be produced within the vendor's recommended range of exposures. There's also processing indications when we're manipulating electronic data, and there are choices we can make with that are determined by the available algorithms. These are all mathematical things that are embedded in the vendor's software. Brightness and contrast can be changed, as I mentioned earlier, but should not be changed before the physician sees the image. And then cropping and masking off anatomy, done under certain circumstances, but don't forget, cropping the image to make it look nicer is not the same as collimating. It's strictly for the appearance of the image, not for radiation safety. The chapters referring to patient interaction and management in your textbook discuss professional attitude, professional communications, verbal and nonverbal communications, giving, receiving instructions and information, patient education, barriers to good communication, some special circumstances that surround that, how to communicate with patients, families, and coworkers. All of these things in these few slides that we are talking about now with patient interaction and management, you've discussed previously in whatever other allied health field that you've been part of. So we are using these slides and this content as review, and there will be some practice questions available to you, especially when you get ready to prepare for the test. Then, safety and infection control. How important. General safety measures, body mechanics, assisting your patients, and infection control, understanding microorganisms, pathogens, infectious diseases, the cycle of infection, standard precautions, medical surgical asepsis, and MSDS. One thing in particular relating to radiography is fracture terminology. That can be found in Figure 1242 in your textbook Radiography Essentials. At the bottom of the syllabus for each of your sections, you'll find the assignment. This assignment for Chapter 1, for Section 1, is read Chapters 1 and 2 and then reference Chapters 20 to 22, the ones that these last slides have referred to, as review. Then view the programs on the flash drive. This first one is called Coreintro, Introduction. It will be on your flash drive, titled the same as you see it on the assignment in the assignment section of the syllabus. View any movies that are assigned. Clinical assignments 1A and B are for this first section. Don't be surprised that the movies and some of the demonstrations include references to film screen technology. Although fewer facilities are using that imaging method now, understanding the content is still helpful. We're not trying to hold you accountable for understanding film screen technology, but we're using this to demonstrate certain elements of imaging that aren't able to be seen with digital imaging. Do clinical assignment 1 and submit it. Do self-test 1, copy the answer sheet, and submit that. Just the copy of the corrected answer sheet. Then copy page 17, have it signed, and submit it as well. This is your supervisor's initial signature. This is the end of Section 1. Complete your assignments and then go on to Section 2.